Okay, moving on. Second case study, maybe one case study would have been appropriate, but second case study. Oops. Non-small cell lung cancer. It's quite an interesting condition. 85 to 90% of lung cancers are non-small cell. The non-small cell lung cancers themselves are further divided into squamous cell, adenoma carcinomas, and large cell carcinomas. The majority of cases are symptomatic on presentation. Occasionally, someone might have had a routine chest X-ray and the problem is spotted, but usually symptoms develop over time. Patients eventually consult their GP, and the GP eventually realizes it might be lung cancer. And quite often, the disease has spread by that stage, which is quite unfortunate. So in England, 2013, almost a quarter of the patients presented with stage 3 disease. So that's locally or regionally advanced. And 46% with stage 4 disease where there's been metastases, and so the disease has spread to other parts of the body. As a consequence of this fairly late detection, the prognosis for these patients is very poor. So median survival with lung cancer is 6 months. 35% of people with lung cancer and 14% of people with stage 4 disease survive more than a year. So it's bad. Choosing your cancers, don't choose this one. Probably, don't want to be facetious, but probably choose to be a man and choose to have prostate cancer. That's terrible. There are still obviously serious cases there, but it just tends to be such a slow-growing problem. Okay, the good news for these patients is there's been a lot of therapeutic advance. And in particular, the rise of what are called targeted therapies. And in particular, this thing called EGFR, epidermal growth factor receptor. For obvious reasons, EGFR, so you don't have to remember it. And so there's a certain subgroup of patients, EGFR, TK positive, who have a chance of responding to these new treatments. If you're not in this subgroup, you haven't really got much chance of getting benefit. And so these have been coming sort of thick and fast. Gefitinib, erlotinib, afatinib, necitumumab, and osimertinib. So there's a lot happening there. There's another subgroup, and they're almost not overlapping at all. These are ALK positive. I think it's aplastic lymphoma kinase inhibitors, ALK positive, and we've got these treatments coming along, crizotinib, ceritinib, alectinib, and there's also distinction whether you can use it in untreated patients or whether it will work with previously treated patients. And if that's not enough, even more recently, we've got what are called immunotherapies, and in this particular case, PD-1 or PD-L1 inhibitors. Now, these are creating, the previous drugs are creating a lot of interest because they're targeted. So instead of just giving it to everybody, you are focusing in on the group that are more likely to benefit. So they're quite exciting. These are particularly exciting because the idea is you're not attacking the cancer cells, you're trying to, right word, almost reprogram the immune system, the body's own defenses, to recognize the cancer cells and to kill them. PD is programmed cell death. I mean, wonderful names. I don't know, it's just sort of science fiction. It's just kind of exciting. And there's a lot of enthusiasm for these. These are the main ones. These are the ones with respect to non-small cell lung cancer. Pembrolizumab, it's also finding use with metastatic melanoma. Nivolumab, which has recently been getting approval all over the place in terms of different cancers, but non-small cell lung cancer is one of the early ones. And just coming along now is this other one, atezolizumab. And no doubt in the drug pipeline there'll be other ones still. Now, these are all expensive. They all work to some extent. There is indeed a slight suggestion that some drugs, like maybe nivolumab, there'll be some patients in which it almost is effectively a cure. Now, this is a patient group, I've just given you some statistics, that it's really, literally, almost the worst news you could get. Oh, sorry, you've got non-small cell lung cancer. The survival is so poor. And so suddenly we've got these things, new drugs, changing the whole prospect. So it's that problem again. We've got a patient group who needs something. We've got drugs that may be able to give it to some extent. And we've got a high price. Now, of course, what we could say is, great, these new therapies, we must have them, and we'll just take the money from somewhere else. We could do that. But you have to remember, in taking the money from somewhere else, there's some other patients who are going to suffer. You could, of course, just say, we'll increase taxes. And it doesn't sound the same kind of suffering, but the taxpayers are going to suffer because they're paying more tax. And, well, governments really don't like raising taxes, or politicians don't really like raising taxes. And I've yet to meet anybody who really likes paying taxes. The way I look upon it sometimes is, well, if I'm paying more tax, it does mean I've earned more. So that's a good thing, isn't it? So, fine. I can't get more enthusiastic than that. Some people at election time will say, you know, sometimes a party will say, look, vote for us, we will increase your taxes, but we'll put it into education, or we'll put it into healthcare. And a small number of people vote for them. Not the majority. So we have a real problem here. Now, there's different ways of resolving it. You could say to the oncologists, say, look, tell me, is this really a good drug? And if they say yes, we need it, you can say, right, we're going to buy it. That'd be one way of making decisions. Another way of making decisions is to say, okay, we'll set up a sort of committee structure, we'll request evidence, and we'll give you guidance as to how you put your evidence together. Evidence on clinical effectiveness, evidence on cost effectiveness. We'll carefully review the evidence. We'll have witnesses and ask them questions. We'll then discuss among ourselves, should we or shouldn't we recommend this drug? That's the nice appraisal approach. I think that approach is better. I think that's a better way of doing things. There's a possibility of being quite transparent, because you can make a lot of the data and information available to other people. The meetings are open to the public, so in principle people can sit and listen to part of the meeting. I think there is another alternative, and I wouldn't mind trying this one, and you just say to the oncologists or all those involved in treating the cancer patients, this is your budget. We're not going to change it. Tell me, how do you want to spend it? Do you want to spend more of it on pembrolizumab and nivolumab, or do you want to provide more palliative services? Or do you want to provide more detection services? Do you want to invest in more screening for early detection? Doesn't get rid of the problem, but this group might then be quite good at seeing the opportunity cost. But right now that's not the system in any country I know, and so basically clinical groups, anything new, they typically want it. Because they're not paying the price. It's elsewhere in the health service the price is being paid.